And a lot of people don't know it. It makes sense to a lot of us knowing that. But today, we got more stuff. All right. So, the question that keeps popping up again and again and again. People writing to me.
Oh, okay. It's good. Hello. It looks like it's got it starting up here.
Oops.
Hi, Jack.
Is he the host?
I have no idea.
Yeah.
I don't know. Somebody should tell Janet not when they have her head.
No.
There.
Our audio was.
Buddy. Hi, Dr. Webb, Dr. Caldwell. Good to see both of you.
Hello.
Sorry, we had a little confusion this morning with Dr. Caldwell's codes.
Okay.
I guess we'll get started in just a moment. I had a jackhammer in front of my house. I had to run down and ask them if they'd stop. So I'm a little out of breath. Okay, I guess we'll go ahead and get started. I believe Madeline was actually going to open the meeting and had a few announcements. So Madeline, are you there?
I am here, and I will. Yes, my name is Madeline Garr, and I'm the president of the League of Women Voters of Nashville, and I want to welcome all of you today. As you know, the League, or you may not know, offers hot topics every month on the first Friday. And it's open to all in Nashville, so tell your friends, whether they're League members or not. However, we would love for people to join the League, and you don't have to be a woman to do it. And if you are interested, go to our website, it's LWVNashville.org, and you can get more information. And as most of you know, Nashville is celebrating the 100th anniversary of the ratification by Tennessee of the 19th Amendment. The big celebration day is August 18th. And one way all of us who are trapped in our homes can participate in this is by ringing the bell. This is a event that's being sponsored by the Nashville Public Library. And if you're interested in that, the time is between 12 and 12:15, and find a bell and bang on it outside. Because churches are going to be out there ringing bells as well. And if you're more interested in more information about that, go to the public library website. And finally, that night between 6 and 9 p.m., the Nashville League, in conjunction with the Nashville Ballet, is presenting 72 Steps, which is a ballet commissioned by the League a few years ago, telling the story, the 72-year history story of the efforts to get suffrage for women. And so if you go to Nashville Ballet website, you can sign up for that free link. It's going to be a free digital presentation. So Ethel, I'll turn it back over to you. Y'all enjoy this. And I'm grateful to the doctors for being here to help us through this difficult time.
Thank you, Madeline. I'd also just add a quick announcement that our September hot topic will be on the second Friday instead of the first because of the Labor Day holiday. We'll have two environmentalists speaking, Noah Chamey from Radnor to River and Karen McIntyre, who is leading a major successful school composting program at Westmead Elementary. And with that, I'd like to welcome our two speakers. I'll give you a little background on them. Dr. Michael Caldwell joined the Department of Public Health in early March 2020, just as the devastating tornado hit Nashville. And the first case of coronavirus was detected in Nashville. So welcome to Nashville, Dr. Caldwell. He leads a department of nearly 600 staff serving our population of about 750,000. He served for 19 years as the Commissioner of Health for Dutchess County, New York, and that's where the home of Franklin and Eleanor Roosevelt is. While there, he managed a staff of 180 employees and a budget of $40 million. He was president of the National Association of County and City Health Officials and also worked as a resident physician with ABC News National Headquarters at their medical unit in New York City. Dr. Caldwell brings expertise on a wide range of public health issues, including infectious diseases, vaccines, tobacco control, emergency preparedness, health equity. He received his undergraduate degree from Columbia, a medical degree from Mount Sinai School of Medicine, a master's degree from Harvard School of Public Health. I guess I would ask everybody to please put your mute on if you could. I think we're getting a little bit of background noise and conversation, and I probably have a way to do that, but it'd take me a minute to figure it out, so thank you. Our second speaker, Dr. Joseph Webb, has been the Chief Executive Officer of Nashville General Hospital at Meharry since January 2015, bringing 25+ years of proven expertise in managing for-profit and not-for-profit healthcare organizations. He's known as a visionary and transformational leader. He has demonstrated success as both a fiscal and operational change agent, beginning with Healthcare Services of America at Coastal Carolina Hospital, where he served as CEO. He then served 17 years with Methodist Le Bonheur Healthcare in various positions, including Vice President of Operations at Methodist Le Bonheur University Hospital. His prior experience includes Chief Operations Officer at Northwest Mississippi Regional Medical Center in Clarkdale, Mississippi. He is a board certified in healthcare management, a fellow in the American College of Healthcare Executives. He obtained his doctorate and master's degrees in health services administration from the University of Alabama at Birmingham. Holds a bachelor's degree and Master of Science in Health and Phys Ed from Tennessee State. I guess I would ask Dr. Caldwell to go first and provide kind of an overview of COVID-19 virus in Nashville, and then I'll ask Dr. Webb to talk more specifically about how the virus is affecting his hospital and the minority populations in our city. I would ask everyone, if you have questions, we'll take them after both speakers talk. And if you would use the chat box on Zoom to ask those, we'll try to get to all of them. We also have questions that were submitted in advance. I'll try to get them all done, but we will try to be done at 1 o'clock. So anyway, with that, Dr. Caldwell.
Thank you, Ethel. Thank you all for joining today. I'm going to try to share my screen now, so hopefully this will work, although it does say the host disabled participant screen sharing. I'm not sure if you're able to allow that. Try that real quick. If not, I'll just try to, I have some slides I was hoping to share. Otherwise, if we can't figure it out, then I'll just try to do it verbally.
I guess the person who was handling it left. So, and I'm not sure how to, if I just hit share screen, I don't know if that would, if that's just me.
Are you the host?
Well, I'm sort of, I think I got just handed to the host, but I was not the host. I wasn't the one that set it up. Anybody know on there?
If he hits share screen, he ought to be able to share his screen.
Yeah, I'm getting a message saying host disabled participant screen sharing. So that's
Okay.
all I see.
Ethel, you are the host, so you have the ability to do this. Go under participants, and there should be a
Okay.
place for you to enable screen sharing.
Clicking participants and clicking the microphone. Okay,
Yeah, thank you for trying. I'm sure the presentation would be much more enjoyable if I could share it. So thank you.
Voters. Share. I'm sorry, I don't have the directions on how to do that, and I'm not seeing it. So I guess I would say just go ahead and do the best you can, and my apologies. We're an amateur group that is still figuring out how to do Zoom.
Yeah, no problem. Well, I'll start verbally, and if you're able to figure it out, then yeah, I could maybe do some highlights at the end.
Okay.
So I'll just kind of talk from my presentation as if I'm giving it. So anyway, today I'm happy to provide an introduction of myself to you as the League of Women Voters. I'm not new to the League of Women Voters. I've been a great colleague and admirer and partner with the League of Women Voters for all of my career. I know that a lot of the mission, vision, and value of the League of Women Voters is closely aligned to the Department of Public Health. Your commitment to diversity, equity, and inclusion is something that really dovetails perfectly into what is important for us at the Nashville Davidson County Department of Public Health. My experience with the League of Women Voters goes back to my time as the Director of Public Health in Dutchess County, New York, where the League of Women Voters was very active at the state level and the local level, and joined us in a great wide variety of public health initiatives. And one that I was very involved in was the one on tobacco control, as well as environmental health. And I know that environmental health is very important to the League of Women Voters, and you have advocated on environmental health issues throughout the state and throughout the country. And I want to thank you for that. And I look forward to partnering with you now that I'm the Director of Health here. I made a note that the League of Women Voters in Knoxville County area specifically has a section on public health. So I'd like to help you to maybe focus a little more just on public health overall. And today my presence here might be able to offer a partnership and maybe interest a few of the members to think about creating maybe a specific section on public health. Of course, everything you do in some way is tied to public health, but I'd like to put a little more emphasis and asterisk to it, just to let everyone know that you are really a true partner in public health overall, not just with every single issue that you oversee. I know that there has been great interest in a lot of the issues around immigration and the census, of course, as well as a whole host of other issues that are really important to the work that we do at the Nashville Davidson County Health Department. So let me switch over for a moment now to COVID-19, which I know is impacted all of us for so long, and it just seems that it just is not ending, and it's getting worse, but fortunately now it's plateaued and seems to be getting a little better, at least here in Nashville. I want to make sure you're all aware of the website where we have most of this information. It's covid19.nashville.gov. Another way to get to it is asafenashville.org. And there, that's our Metro and Mayor Cooper's main interface page to provide you updated information. It's updated every day and sometimes more than one time throughout the day. Usually though, in the mornings, just after 9:30. We look at a number of key metrics to decide how we're doing, and those are all outlined for you to see. One of the things that we've been most concerned about with COVID-19, not only here in Nashville, but across the country, is that there are disparities with COVID-19, and that COVID-19 is disproportionately impacting minority communities. Some comments of some of my colleagues across the country have noted comments like this: a lot of epidemics are like guided missiles, attacking those who are poor, disenfranchised, and have underlying health problems. And that was by a comment by Dr. Thomas Frieden, who is the former director of CDC and a colleague of mine. And COVID-19 is really no different. I have been working with a number of colleagues who are dedicated, like you at the League of Women Voters, to try to educate and communicate and help build partnerships to advocate for reaching out to the minority community. And one example of that was working with the Metro Minority Caucus to host a webinar for the minority communities with Metro Council at-large member Sharon Hurt, who also is the chair of the Health and Human Services Committee. That is online at that asafenashville.org, and I could send that link to you so you can get updated on the information we gave at that particular webinar. So for the number of cases that we have now in Nashville, Davidson County, we have over 22,000 cases, over 200 deaths, both confirmed and probable. Fortunately, the number of cases seems to have tapered off slightly. Really, it was in May 25th, Memorial Day, when we went from phase 1 to phase 2. At that point, there seemed to be a slowly and then more rapidly taking off of acceleration of cases through about July 4th. Mayor Cooper and I both pulled back from our phases from phase 3 back to an abbreviated modified phase 2. Since early July, we have seen a slow decrease in the number of new cases, although the cases are still at an unacceptably high level. Not surprising, once we saw the cases starting to peak in early July, we would have expected, as we are seeing now, the hospitals and deaths have increased, and the hospitals are at a very full capacity, and they are preparing contingency plans in case they need to open up additional beds. Right now we feel that there are enough, and we're balancing that with our colleagues at the Tennessee State Department of Health and as well as our colleague hospitals. And I'm sure Dr. Webb will give us some feedback on what's happening at his institution. We are seeing some promising signs in both the 14 and 7-day case trend of the number of positive tests. So what I look at is not how many positive cases there are every day, but what % of the overall tests were positive. So whether you see we had 100 new cases or 500 new cases, I'm always looking at that denominator. How many tests did we do to get those positive results? So clearly, more positive tests is a concern, but for me also the percent positives, the attack rate is a concern. So right now we're seeing approximately a leveling off of about just under 12% positives. We'd like to get that well under 10%. Now this was as high as 18% just 3 weeks ago. So we have really made a lot of progress in the last few weeks. We're down about a third of the number of cases. The active number of cases now in Nashville, Davidson County is just over 3,000. That's half of what it was just a few weeks ago. That's good news, but the other news is that even though it's half of what it was 3 weeks ago, it's still 50% more of what it was at the end of May. So we still are not quite where we were at the end of May. We were where we were probably by about the middle of June for the number of active cases right now. But what if some of the positive trends that have occurred, the face mask order, the orders to keep the bars closed, the work now with Mayor Cooper and the office to all of our Metro colleagues to increase enforcement efforts. And you'll be seeing a lot more activity over this weekend that will be very visible. And we are hoping that this will continue our downward trend because it's important that we get to a point where we can get somewhat back to some normal activity. Wearing face masks, enforcing social compliance, enforcing face masks, and trying to restrict and limit alcohol, which really impairs people's judgments, and keeping as many activities outdoors as we can. These are the keys for us to being able to try to slowly reopen and get back to some normalcy. You may have seen some recent news about there being vaccine trials available in Nashville, Davidson County. And I would like you all to learn about the opportunities that exist at Vanderbilt, as well as Meharry, as well as an organization called Clinical Research Associates. Last night, the Board of Health approved our Nashville, Davidson County Department of Public Health to participate with Clinical Research Associates on a COVID vaccine clinical research trial. We want to let everyone know that these research trials are starting to recruit participants from a number of different institutions. There will be more than one vaccine type being tested here. And I think that's really great opportunities for people who want to learn and be a part of a research project, because only by doing research will we know if the vaccines that are being developed are going to be safe and effective. Good news is that these are all trials that are phase 3 trials. And what that means is they've already gone through phase 1 and phase 2, where numbers of hundreds of people have already been tested with these vaccines. So there is some data that exists already for safety, as well as positive immunogenicity data, which will allow these vaccines now to get to this next phase, phase 3, where tens of thousands of people across the country will be participating. These trials are usually set up with a blinded, double-blinded placebo control. So approximately half of the people who participate will just get a placebo, half will get the vaccine, and they'll be monitored closely. So we'll be monitoring for safety. We'll be monitoring for see how the antibodies are impacted or affected by these vaccines. And more importantly, we'll be monitoring to see if these vaccines actually prevent COVID. It's really exciting. This is what we've heard over and over again is going to be able to get us out of this epidemic, is to be able to try to get a vaccine that works, and hopefully we'll have more than one. Let me take one step back to share with you some data regarding how the number of deaths are distributed along the different age groups, as well as the racial and ethnic groups. most of the people who have died in Nashville, Davidson County have been over the age of 65. Approximately 4 out of 5 deaths have been in ages over 65. That means 1 out of 5 were below that. So we have had approximately 150 deaths over the age of 65. We've had about 50 deaths below that. We've had deaths as young as in the age 30. We've had 13 deaths in the 45 to 54 category. And in the 55 to 64 category, we've had 35 deaths. Now, oftentimes we'll say that the majority of these individuals that have died from COVID also have something called underlying conditions. Well, let's be real here. Most of us have some underlying condition, whether it be somebody's a smoker, or somebody's overweight or obese, or somebody has diabetes or hypertension. 40%, let me say that again, 40% of people in Nashville, Davidson County has some underlying condition. So don't just think, oh, those people have some underlying condition. That's not me. In fact, it may be we may have some underlying condition we don't know about. So all of us are at risk. All of us need to be able to assume that we have COVID at all times, and know that that's important for us to wear the face mask, and know that anyone we encounter, whether they look ill or not, may have COVID, and it's important that they wear their face mask to protect you from them. I'm going to spend another couple minutes talking about the problem of the impact in the African American community as well as the Hispanic community with COVID-19. We have seen a disproportionate number of cases in both the African American community and the Hispanic community. Overall cases of COVID to the overall population of these community members in our community, as well as deaths. Now, the deaths primarily have been African American deaths disproportionate to the overall deaths. The Hispanic deaths actually haven't been as high, and we attribute that to the younger age category of the Hispanic population that has gotten COVID. So remember what I said earlier, the older patients are more at risk, and that really goes across the board for all racial and ethnic diversity. So what we're seeing is the older Black population being mostly impacted at a much higher rate than what their population is in the community.
Dr.
Yeah. Oh, yes. I'm
Dr.
here.
Cole, I think we might need to turn to Dr. Webb for a few
Okay.
minutes.
Yes. Well, let me go ahead. I'll conclude there. Thank you so much, and I'll be happy to take questions.
Okay. I think we're going to do questions after both of you have spoken. I think I have loosened up the restriction on posting.
Yes.
So when we get done with him,
let Dr. Webb go through his talk, and then maybe once there's questions, I could share some of my screen. Thank you.
Okay, great. Thank you. Okay, Dr. Webb.
Well, good afternoon. Interesting information coming from Dr. Caldwell, and I appreciate the voters for hosting this event and for facilitating this process. So Dr. Caldwell covered the health aspects of COVID-19. So I'm going to take a little bit of a different approach. The hospital itself, just to update you on that, Nashville General Hospital averages anywhere from 5 to 10 COVID-19 patients on a daily basis. And we do what we normally do. We take care of individuals that are sick, and we try to make them well. We have a intensive care unit here that, for the most part, houses our patient population, and it's a normal process. It is a a virus, and so it is a very infectious virus. So we do care for it in our intensive care unit in negative pressure areas, and try to make sure that our first line caregivers are kept healthy. But I want to take a little bit of a different approach. This gives me an opportunity to share some of the overarching issues that are associated with COVID-19, particularly in the community. The title of this program today is, I understand, the virus in our village. And the virus in our village might not be exactly what you think it is. So let me share a little bit with you on that. I always like to start my conversation, since I am a healthcare delivery services expert. I like to start by just coming to an agreement on what health is actually. And according to the World Health Organization, since 1946, this definition has been, it's a state of complete physical, mental, and social well-being, and not just an absence of disease or infirmity. So healthcare is a source that connects an individuals to their health. And without our health, for the most part, not much else is going to matter. The challenge of healthcare delivery for us in the United States here has been persistent, and it continues to grow. Our policymakers are having a tough time and don't seem to be able to agree on what the value proposition is for healthcare for this nation. What the individuals want, need, and deserve seems to be an elusive concept for our policymakers. So to further complicate matters, and this helps to frame the discussion, healthcare in the United States is not a right. You won't find it in the Constitution, and you won't find it in any statute. It tends to comport with the theory of consumerism. The more goods and services a culture consumes, the better its economy and the stronger its economy is going to be. So here are the systemic conditions that we deal with. The systemic conditions. Certain social environmental factors put some groups at greater risk of adverse health outcomes than others. You heard Dr. Caldwell speak to some of the disproportionate impact among people of color. The social determinants of health is how this seems to manifest itself. And the social determinants of health are really defined as a distribution of the economic and social conditions that have an influence on health status and health outcomes. They are things like education attainment, access to adequate income, access to adequate health care, access to healthy food, access to adequate housing, and access to adequate transportation. Now, when there is a maldistribution of the social determinants of health, it's usually caused by poor social policies and unequal economic opportunities that tend to exacerbate how individuals fare in their healthcare outcomes. To exacerbate matters a little bit worse and make them a little bit worse, only 12% of the total population is actually health literate. What does health literate mean? Health literate really means that if your healthcare provider gives you information on your condition and you're able to utilize that information to improve your health condition or to apply it to your health condition, then you're considered to be health literate. If you're not, you don't understand it, you can't grasp it, then typically you're considered health illiterate. So with only 12% of the population, total population, actually being health literate, when you factor in all the social determinants of health, you could probably figure out pretty easily that those individuals that are dealing with the social determinants of health will likely be less than that 12% to be health literate. So that's another issue that we have in our community that creates a challenge for us. So the social determinants of health are fundamental causes of health disparities. So what's a health disparity? health disparity is the differences that remain after healthcare is received when you take into account the needs and the preferences and the available resources. So just to give you an example of that, I'm going to separate this group that's on this Zoom activity into two groups, Group A and Group B. You can self-select into whichever one you want. So Group A, you have a health condition and a need. Group B, you have a health condition and a need. Group A, you want to receive care. Group B, you want to receive care. Group A, care is available and the resources are available. Group B, the care is available and the resources are available. Group A, you receive the care. Group B, you do not. That's a disparity. It doesn't matter what caused it. It tends to be associated with a health disparity, particularly when it becomes a chronic practice. So health equity is another part of health disparities that if we can achieve health equity, it means that we've dealt effectively with health disparities. So what is health equity? And another definition that came from the World Health Organization, everyone should have the opportunity to attain their full health potential. No one should be deprived of this potential because of socially determined circumstances. So that's how health equity is associated with our culture. Everyone should have access to that potential. So what's the current challenge that we're dealing with? Evidence from past epidemics and natural disasters suggests that most socially marginalized populations will suffer disproportionately from those disasters and epidemics. And you heard Dr. Caldwell speak to that just a moment ago. So we're seeing that play itself out with COVID-19. The data is showing that there's a stark racial disparity in rates of COVID-19 cases and mortality, which is death. The percentage of African Americans affected is more than twice as high as the proportion of African Americans in the overall population. So why does this challenge exist? Here's what research shows. Minority African Americans and African Americans receive poorer than average health outcomes in general. African Americans are 80% more likely than whites to have diabetes. 1 in every 4 African American women over 55 has diabetes. 11.4% of all African Americans over 20 have diabetes. African Americans are twice as likely to die from diabetes than whites. Elderly people of color are the most at-risk population when it comes to receiving inadequate or inappropriate health care. African American babies are 3 times more likely to die within the first year of life than whites, and that's infant mortality. African Americans are more likely to suffer from congestive heart failure than any other race. Colon and rectal cancer death rate is 50% higher in African Americans than in whites, and African American men are 60% more likely to develop prostate cancer and twice as likely to die from it. So large portions of African American, in addition to all of that, have a high level of mistrust for health institutions. So that tends to exacerbate the care also that that particular population receives. So how do we address the virus in our village? You have to first remove the constraint that prevents us from eliminating health disparities and achieving health equity among minority populations. Now, a constraint is something that imposes a limit or a restriction or prevents something from happening. The disproportionate impact of COVID-19 among African Americans is a symptom. It is not the constraint. We should not spend our time chasing symptoms and ignoring the true constraint to health equity. The intervention that is needed should address the social determinants of health. In other words, the social inequalities that exist in our culture. The constraint is that this is your virus in the village. The constraint is your virus and the village as it relates to the social determinants of health, which create the backdrop for all of the conditions that you just heard and the outcomes that you heard, as a marginalized population is more highly affected whenever it deals with pandemics, epidemics, or natural disasters. So health equity cannot be achieved until we figure out how we're going to create a more equitable distribution of the social determinants of health. The maldistribution of the social determinants of health is actually what creates the problems that we have, because it tends to manifest itself into a limited population, and then we see the disproportionate outcomes that we see among the more marginalized members of the population. So what can we do? Here's the call to action. We can discourage policymakers and leaders from buying into the rationalization that most social problems are racial and of concern to minority interest groups. We must avoid allowing harmful myths to be rationalized as causes for disproportionate impact on minorities, such as biological explanations for racial disparities. In other words, African Americans or other minorities are biologically predisposed to the effect that they receive in certain conditions. Racial stereotypes about behavioral patterns, such as they're not compliant. They are just not compliant, so these things will naturally occur when you're not compliant. There's another one, geographic disaggregation. These problems are created within their own communities, is another myth. So the challenge to policymakers and elected officials to address upstream policies, those policies that create these social determinants of health, is where we need to focus our attention. So in conclusion, Reverend Dr. Martin Luther King took this position on healthcare. Of all the forms of inequality and injustice in health is the most shocking and the most inhuman, because it often results in death. And injustice in health is the most shocking of all inequalities. The United States has needed stronger motivation to effectively address the social determinants of health for some time, as well as health disparities. COVID-19 just might be that wake-up call that's needed. Thank you.
Thank you. Thanks to both of you. We have about 15 or so minutes for questions. We've got several that were submitted. Dr. Caldwell, I don't know if there are any particular slides you wanted to show from your presentation, or if maybe we could send those out afterward or something. Would that be a possibility?
Oh, definitely. And we'll try to, I've abbreviated just to show a few slides if I can, while you're doing the question and answers, just maybe as a background.
Okay, that would be great. I guess I have some questions for both of the doctors. I guess, how are the cases and hospitalizations breaking down in terms of insurance status? Are more privately insured, under Medicare, TennCare? How many people have no coverage?
Well, traditionally, it depends on what type of hospital you are. Obviously, if you're talking about Nashville General, which is a public hospital, one of our primary focuses is to care for the population that does not have other means of covering their healthcare costs. So for us, we look at about 40 to 45% of our patients here who have no means of coverage. So the other portion of the population will have some form, whether it's Medicaid or Medicare or some commercial type of insurance. So that's the overall breakdown of the payer mix for Nashville General.
Okay.
Obviously, if you look at an HCA, which is a for-profit system, you find a lot more of those that will have the ability to pay, and then it will start to move from there to the private, not-for-profit hospitals like Vanderbilt and Ascension or St. Thomas.
Okay. I have a question. This one may be more for Dr. Caldwell about how will testing be handled in schools after they open, and will that affect turnaround time? Maybe I also have some questions about the current turnaround time, so maybe just talk briefly about the testing.
Yeah, well, schools is something that is an ongoing conversation. Dr. Jahangir, who is the chair of the coronavirus task force, has taken a lead on that with Dr. Adrian Battle, as well as with our director of school nursing. We at the Department of Health provide a lot of the school nurses. So we don't have a specific guidance yet on how testing will work out. We may learn a lot from some of the private schools that are already starting to go back to see how what they're doing and what we'll be looking at for CDC as well to see what their guidance is. But we have a lot more to learn. You're right that testing is still a problem regarding not being able to have sort of a very quick test. There are more evolution in technology, new types of tests which are coming up so that we can kind of get test results within 15 minutes or so. That's going to be a lot more useful to us than the types of tests now where you have to go and wait a few days and you're not be sure. This is a good time to just take a step back and know that no matter whether you're being tested or not being tested, if you don't feel well, then you should not go out at all. If you do feel well, you should just assume that you have COVID and that anyone around you has COVID. So you should always be wearing your face mask, always be washing your hands frequently, always be socially distancing. So then if somebody actually does test COVID that you know or you've been around, you know that you have always, in all your encounters, done the best you can to have reduced your exposure, limited your likelihood of getting it. So if we all did that, I think we'd really continue to make a lot of progress.
Okay. The league registers a lot of voters in different places. We're going to be in the farmers market in September and October, and I guess we're wondering if it's possible to get someone from your department to actually meet with us on site and help advise us on the best ways to do that.
Yeah, just email me and we've got a program to be able to provide guidance to you.
Great.
I'm showing a slide now, which you could see. Are you able to see the slide I'm showing?
Yes, I can see it.
Great. So starting from March 9th through recently, you could see how we were really kind of flattening that curve throughout May, and then things really took off mid-June, peaked early July, and now we're back down again, probably about where we were in mid-June. Still have a ways to go. So this is just one example of where we are and just a picture. You could find more information like this on asafenashville.org. There's a lot of great information. You can go down below the bottom page, click on where it says, show me more data on the dashboard, and you could have a lot of fun seeing all different graphs like this and really getting a good picture and understanding in detail about the data. And if you have any other questions, we're here to be able to try to answer them for you.
Okay. Dr. Webb, I think I have one for you. We read that hospitals need to begin paying back money that's loaned to them as part of the stimulus packages. Has that affected Nashville General, and how has the COVID virus affected your hospital's budget?
Well, initially there was a fall off, a drop off of volume, particularly in our clinics and in areas such as our operating room. We have recovered for the most part from that. Our volume is back up. That lasted for several weeks. So it will put somewhat of a drop in our revenues, but to a large degree, we won't be affected from an annual standpoint. We'll recover from that. The payback has not impacted us. We still have access to some CARES funds that we have in the bank. You might have seen some of that in the media. The funding, 9.4 million, which we would have to demonstrate utilization of those funds through COVID-related activity through the end of the year, December 30th. So we're faring pretty well through all of it, and I think again the volume is slowly coming back.
Okay. Who sets the standards for protective gear in the polling places? So our questioner thinks we're sending the wrong message with workers wearing gowns and gloves, and that maybe this isn't appropriate or a good use of supplies.
Well, we have a colleague, Dr. Gil Wright. He's an occupational health physician and is an advisor to the elections bureaus. People can choose to wear what they're most comfortable with. I voted yesterday and you did not see that type of PPE. Social distance is really important, but we'll be working one-on-one with the election commission to provide them the information that they need so that they can feel comfortable and stay protected.
Okay. How safe will it be to participate in the vaccine trials? They're not talking about the vaccine specifically, but whether they would be going in somewhere and exposing themselves to other people and vice versa.
Oh, that's a really good point. Well, we're certainly going to be requiring everyone to wear face masks and socially distance no matter where you are gathered. We're not going to have lots of people coming in one particular place. So all of those guidelines will be continued. So if you are going out, you would recognize that wherever you may go to try to learn more information or explore about one of these opportunities to do research for vaccines, that you should feel safe there. Each one of these will be a different vaccine and a different protocol. And it is research, so you will be fully informed about what that particular protocol is, what the risks are known, what's unknown. Make sure you understand it. Understand that you might get the vaccine, the research vaccine, or the placebo. Understand how you'll be monitored. Understand that you can stop the process at any time. How many visits there might be, how many blood draws, how many vaccines. From my experience and what I have seen, it's likelihood that the introductory visit, if you meet the inclusion and exclusion criteria, which means you're generally healthy, and if you do have health conditions, they're under control. I know they're definitely looking for a larger number of people over the age of 65. Now, that makes sense because those are the people most at risk of dying, and we really want to make sure that this vaccine is effective in that population, probably more than anyone. So anybody from 18 years of age and older who is interested, you can just learn more about it, and you may learn about it and you may decide, no, it's not for me. But I think the great thing is that we give people an opportunity to learn as much as they can and decide if this is right for them. You know, we're the volunteer state, and I know this is a great way. We've never asked people to volunteer in such a way as this, but we need people. And these are the people we look up to. If we didn't have people volunteering for clinical research studies, we'd never really be able to understand things. So we are really grateful to those people who step up want to participate. And I'll be happy to continue to provide you information on the menu of different places people can go to get more information. So thank you for that question.
Okay. What is being done to target testing to minority communities and to help them follow up, particularly if they are uninsured?
Gee, I guess here you go. I just happened to get this out. Hopefully you could see this, where Meharry has really taken a leadership role with Nashville General to specifically target the African-American population at Metro Department of Housing centers, as well as churches, as well as now we're making inroads into not only the Southeast, because the Hispanic and multicultural communities that are greatly impacted are not just in Southeast, they're in other parts of the county. So we call this the At-Risk Nashvillians Plan now. But we are working with trusted partners such as, and you could see some of the areas that have been impacted with these heat maps that continue to be updated and available online. But we're working with colleagues like Siloam Health to target the immigrant communities, Conexion, and the Tennessee Immigrant and Refugee Rights Coalitions. We are working with other churches within the immigrant communities to do special testing days on the weekends as well, to accommodate people who may not be able to make the Metro assessment centers. Now those centers have shifted to summer hours. They're open from 7 a.m. to 1 p.m. There are also the 3 sites at the Nissan Stadium, at the old Kmart on Murfreesboro Road, as well as at Meharry Medical College adjacent to Nashville General Hospital. Thank you.
Okay. Dr. Webb, this one is for you. When uninsured COVID patients come to Nashville General for care, are you able to bill the federal government directly, or does it go through the state of Tennessee or some other method?
Well, that would be captured in the impact of services through the CARES Act fund that we have to justify before we can actually retrieve them. Again, it's just it's allocation, overall allocation of what they project would be the losses, but you continuously have to justify those losses. So that would get factored into some of the areas where we would, you know, of course, if you really think about it, that's largely why we exist, is to care for populations who don't have the ability to pay. But any excessive over and beyond that could be justified in retrieving funds from the CARES Act allocation.
Okay. We've seen a variety of immigrants in Nashville. Are you seeing cases across the board in these populations, or are you also seeing a disparity in these? I think one of you mentioned that earlier, but maybe just touch on that again, please.
Well, yes, a lot of immigrants typically live in homes that typically have many members of their household and very little space. So they're unable to socially distance the way people who are not in those conditions are able to socially distance. We also know that a lot of them, when they do go to work, they carpool and are often in cramped quarters going to or from work. And when they do get to work, these are our healthcare providers. These are our other essential workers. You remember earlier in the epidemic, there was an outbreak at the Tyson Foods facility. There are outbreaks ongoing on and off at construction sites. So wherever you see the diverse communities and the jobs they take, where they work, where they live, this outbreak spreads. So we're seeing a lot of household spread as well. And of course, these parties whether it be backyard barbecues, weddings, you're going out to bars, anything that puts you in an indoor environment where people are not wearing face masks, they're spending time in close quarters, not socially distancing. And if there's alcohol as well, that impairs your judgment. So all of these factors I call the fearsome four of being indoors, no face mask, no social distancing with alcohol. We're seeing a lot of that. But that's just one piece of it. The other piece is really the, if somebody does bring it home, it spreads rapidly in the home.
Okay. Will the vaccine trials include a representative cross-section of all minority populations in Nashville? I think you've touched on that. It sounded like yes. Yeah. Okay.
Well, yeah, and also know that each one of these companies are doing these studies across the country, and they have working with the FDA goals with certain percentage of the their volunteers have to be in certain categories. But we're dedicated here because we do have a diverse population, because we have a very robust African-American community connection as well as Hispanic connection. We look forward to providing as many opportunities to get those populations to participate.
Okay. I think we have our last question. Is testing for antibodies available, and is there a use for the plasma from those with antibodies?
The antibody tests are still evolving. We really don't have good information about what they mean. So even though you might get a positive antibody test, there's more than one type of antibody test, more than one company. So they really haven't set a range of what it means. So if you get an antibody test and it's positive, that just shows you've been exposed. It doesn't mean whether you're protected. It doesn't mean whether you still might not get it again. But one of the best ways to get more information, of course, is if you are interested in participating in a clinical trial and you feel that's right for you, then you will be getting serial tested of your antibodies, not only to see if you've been exposed, but to see if the vaccine takes effect. That's what we're trying to learn in these vaccine trials, is what we're trying to do is learn to see if these vaccines produce an antibody level, number one, but then what is the meaning of that antibody level? Is that antibody level high enough to protect you from getting COVID? So we're really excited about that. So right now we have still a lot more to learn on that. So don't think that the antibody test is anything more than just a learning process at this point. If you are concerned about COVID, make sure that you get yourself tested.
I think we are about out of time. I'd like to thank both of you very much, and I'm sorry we have to do this by Zoom instead of in person. I would just like our two health co-chairs will probably be following up with you, Dr. Caldwell, because I think we'd like to understand better how we could partner as sounds like the Knox County League is doing. And is it possible that you might be able to share your slides with us? We could send them out to the participants. I think your secretary, Martha, has my email. If you could just send them to me, we'll make sure those get distributed.
Yeah. And I have to say, it's been great to share this podium with Dr. Webb. We've been trying to catch up this week, so Dr. Webb will catch up before the end of the day.
All right.
Thanks to you both. Applause, virtual applause. Thank you very much.
If there are any additional questions, please forward those as well. We'll be happy to. Anybody here, please follow us at Nashville Health. My Twitter's at Health Chief. If you want to visit me this weekend, I'll be down on Broadway from 6 p.m. to 10 p.m. handing out face masks. I'm not kidding. So just come by, say hello. Just wear your face masks.
Okay, great. Thank you. And thank you for doing that. Thanks to you both, Dr. Webb and Dr. Caldwell. And we'll see you next month on the second Friday. Thanks, everyone.